Okay, so we're live. We have Dr. Helen Jones joining us from the UK. It's 10 to 8 in the UK, May 31st, 2015. Thank you, Dr. Jones, for joining us. Would you please go a little bit into your background and tell the parents something about I guess, how you came into orthodontics and maybe a little bit about your educational background?
I trained at Guy's Hospital in London, and after 15 years in general practice, I limited my practice to orthodontics, which I then carried on for the next 30 years. I very soon became interested in early functional treatment and have visited the States, and I've been lucky enough also in the UK to have extremely good mentors, and they've really taken me along this path. I ended up doing some lecturing for the American Association of Functional Orthodontics, and I now continue to lecture osteopaths and chiropractors because they have a holistic understanding and view the mouth as part of the body, and I like to get them informed about this earlier treatment, and that then their patients can benefit from this knowledge.
Mm-hmm, mm-hmm. Okay. I understand that you have now retired from orthodontic practice, but that you continue to enjoy lecturing. Could you tell us some of the topics you like to cover?
Well, in the UK and in North America, the perception that the general public and the dental profession have is that fixed braces are the gold standard, a sort of teenage rite of passage. However, there are other options, and I like to explain that and to also tell about the many benefits of earlier treatment.
Okay. Tell us about these benefits.
Well, we don't know exactly what causes crooked teeth, but in the majority of patients, there are some common factors. Previously, patients and parents were told that the problem was too many teeth, or that the patient had the teeth were too big. Sometimes they said that the child had inherited their father's teeth in their mother's jaw. But the fact of the matter is, when you examine these patients, they nearly all have underdeveloped jaws. And some of them have also a retruded lower jaw, a posteriorly positioned lower jaw. And we now have good appliances where we can develop the jaws, particularly in the growing child.
How does this differ from some of the more conventional treatment?
Fixed braces are usually fitted in the permanent, that is to say the second teeth, and they are only through at the early teenage years, so that delays the start of treatment. But I think an increase in sleep disorders, particularly in children, is raising the awareness of the airway. Children with small upper jaws and retruded lower jaws often breathe through their mouth. That's because there isn't sufficient room for the tongue, and so their mouth is open. And this is a much less efficient way of supplying oxygen to the body. In fact, low oxygen levels have been associated with ADHD, which is attention deficit and hyperactivity disorder, and also the more severe problem of obstructive sleep apnea. Adults suffering from OSA are often fitted with a forward positioning appliance to give more space for the tongue and open up the pharyngeal as the throat airway.
So if you take a kid and they have crowding in their upper jaw, or you take any kid and you put them in an appliance that restricts the growth of the maxilla, are you then in fact restricting the growth of the airway?
I think you must do, because the upper jaw is it's associated adjacent to the cranial base, and we know that the cranial base growth is completed by about the age of 11. So any restriction that you put on there before that is going to be quite detrimental. And of course, if you're only limiting your treatment to teenage years, then you are limiting
Okay. Um, okay, and how about a upper and lower Holly retainers when you fix the width? When you take a kid who's 13, 14, 15, and their face is still widening, and you stop it, or can those retainers have that effect of actually stopping the growth during sleep?
Well, I think the majority of the growth would have taken place by then, but most people who have Hawley retainers fitted have probably had not had the developmental treatment anyway. You're going down a different route. There's the sort of traditional treatment where you just align the teeth and keep the jaw more or less at the growth rate it was at 11, or you have the other approach, which is where you look at the whole of the body, the airway, the head posture. So it's already talking about two different approaches to treatment.
Yeah. So how does the whole body approach improve the situation of a kid who has retruded jaws and possibly sleep apnea and ADHD?
When you're opening up the airway, if the lower jaw is back, then you have a forward head posture. That's because that's nature's way of trying to get a better airway. Of course, that has implications as the patient gets older, because the head is 8 to 10 pounds. The older you get, the more that curve will become more pronounced. What was the other question you asked?
Well, I guess the approach you're talking about, where you're, like a whole body type of approach to orthodontics, is, are we able to increase the pharyngeal airway? Are we able to ensure that it grows properly? And
Well, there is a lot of research coming out now on the benefits of changing breathing patterns.
yeah. So switching from mouth to nose breathing,
Yes.
better oxygenation.
Well, nose breathing is just so much more superior than mouth breathing.
Okay. Okay. So what would
that
you?
affects not only the oxygen level uptake in the lungs, but actually the oxygen level at the cellular level as well.
Okay. Okay. What would you advise a parent who has a child with crooked teeth?
Well, both countries agree that an orthodontic assessment should be carried out at the age of 7.
Okay.
But the reality is that most treatment is deferred until the early teenage years. There are now an increasing number of dental practitioners who have trained in early treatment.
Yeah.
And in a way, this brings it into, it's logical, because in most cases in dentistry and medicine, when a problem is recognized, then treatment is initiated at that stage. And so in some ways, orthodontics has become set apart from that, because they delay the treatment. And that's partly because they rely on fixed appliances, and they are reluctant to maybe to see young children. A lot of orthodontists don't even like the parents to come in. They don't particularly want to communicate. They have full charge of a fixed appliance, whereas with a younger child and removable appliances, you need to motivate, and you need to take the parents on board with you. It's a whole family affair. It's quite a different approach, quite a different method of actually putting over your treatment.
Could you talk a little bit about the Myobraces and the advanced light wire functional, the ALF, and the Bioblock?
Well, the Myobrace system, which is like a double mouth guard, is a trainer system, and it's been around for about 20 years, but it has actually become much more sophisticated now. And it has been introduced into over 100 countries. But as I said in the beginning, the UK and North America have been relying on fixed appliances, so it's been slow to catch on. There is some research showing that these can significantly improve breathing patterns, and also once you move into nasal breathing, you can see a reduction in large tonsils and adenoids, and so that you may not need surgical intervention for that. There are also other developing appliances which can be fitted, say the age of 8 to 10 years. The ALF, which is the Advanced Light Myofunctional, and the John Mew Bioblock.
Mm.
So the extraction of healthy teeth is rarely necessary, and in my opinion, and many others, headgear should be a thing of the past.
Okay. Would you support an official ban on it?
Yes.
Okay. What about self-esteem issues and this method of correction?
Well, young children often get bullied if they have unattractive teeth, and that lowers their self-esteem. If you have a child with a lower jaw that's set back, they look a bit goofy. They don't look as intelligent as other children, and this has a reciprocal effect on the teachers they come across and on their peers. Also, if the front teeth stick out, they're quite likely to suffer damage. So that treating earlier, there's two cases for supporting that. And parents often know, children know, other children in the class know that a child has a tooth problem. That's why they bully them. So that everybody can see the problem.
Yeah.
So why is it just put on the back burner for so many years?
Yeah.
So all the appliances I've mentioned do not pose a problem with hygiene. By correcting the bony and muscle imbalance at an early age, the end result is likely to be more stable and require less long-term retention. And that's certainly been my experience of retainers. I use the suck-down retainers like a Invisalign appliance retainer, but the idea is that after a few months you try it every other night, and then twice a week, once a week, and then hopefully you get down. They just check the position of the teeth once a month. The idea is that it should be stable and that you're just checking, you're not actually holding everything there.
So with this type of functional approach, you've helped the kid's face grow forward. You're not stunting the width of the face, so the airway is the maximum it could be. They're breathing through their nose. They're not breathing through their mouth. At that point, do they need fixed braces, or is that necessary, or what are your thoughts on that?
Well, sometimes there's just the detailed final alignment. It may be desirable to have fixed braces for maybe 6 months, a much shorter duration. And as I said, it's much more likely with a good tongue position, the tongue up in the palate. That the tongue is really a retainer, and is likely to be more stable.
So you're saying there's a natural retention going on.
Natural retention.
The teeth aren't going to relapse if anatomically you've got the right architecture.
Well, I don't know why there is this desire to have teeth that look like a set of dentures. So I think that a little bit of character is fine. I don't expect the bony change to change.
Okay.
And that any movement should be just significant.
Okay. And could this method of treatment prevent obstructive sleep apnea in adults?
Well, if there's this increase in people attending clinics and having mandibular forward positioning appliances fitted, and that is, if you can bring the mandible forward in the growing child, then that must be preferable. I've heard that now in America they not only ask you to take your computer out of your hand luggage when you go through the customs, but that in fact you have to take your CPAP machine out as well. It's actually something that they're asking at the security. So this is an endemic, really, epidemic. So we really need to look at the cause, and the time that we can treat it is in the growing child.
Yeah, sleep apnea is definitely becoming an epidemic. It is. Do you think that the approach is changing and that we're heading in a better direction?
Well, fixed appliances, orthodontic treatment hasn't really changed fundamentally for about the last 40 years. So,
Yeah.
like anything else, you would expect there to be a change and a rethink of what we're doing, because at the moment fixed appliances, they demand lifelong retention. So even at the end of a complicated and expensive treatment, the end result is only as good as the person who wears the retainers. So yes, I do think that people are seeking, the general public is seeking for something better, and I think that that the number of sleep problems, that the awareness of the airway and the connection to dentistry is going to change, and we now have new options for early treatment. We can move away from extraction and retraction orthodontics, but we also need to collaborate with our ENT specialists and pediatricians, which isn't happening in this country yet, but Derek Mahoney in Australia tells me that 20% of his cases are actually referred to his orthodontic practice from ENT.
Interesting. I've been reading old journals, from the 1900s, early 1900s. When the International Journal of Orthodontia, or different peer-reviewed journals, and one of the common threads I found back in the early 1900s is that we should not be restricting the growth of the maxilla. We should be promoting the growth. We should be promoting nose breathing. Mouth breathing is disastrous. It wreaks havoc on health. Extractions have pernicious effects on facial form and should be banned. This is people talking in the early 1900s.
It's been going round and round. It's round.
And
there's a very, very vocal lobby, which I think one could say is turf protection.
That's astounding. It's astounding because if there's been a controversy and a debate going on, and a debate about headgear, a debate about maxillary growth retention, a debate about extractions, been going on for 100 years, the people on the side of the debate who are saying, please do not extract, please do not restrict growth, it would seem to me that they're erring on the side of caution. And that the other group is almost reckless and saying, I hear your cautionary advice. Thank you. I'm not going to take it. I'm going to extract. I'm going to restrict growth. And what do they tell their patients? Do they hide the other side? Do they hide the cautionary warnings of their peers, or do they say, hey, kid, I want you to know there's another side. There are a bunch of people out there who believe that this is disastrous for you, and I just want you to know that I don't believe it.
Well, the General Dental Council in the UK have said that if you don't believe in a different type of treatment, you don't have to tell your patient. And that's not informed consent, and that's another way that we are trying to raise awareness. And it's, I think, the fact that they have research, but if you talk to the head of research, dental research in the UK, he'll tell you that none of it's very robust. They have loads and loads of papers, but when they're reviewed, it sort of says, well, this is interesting, but we need to follow this up with more research. They have many, many, many more papers.
Right.
But, and if you just look at aligning the teeth, it probably doesn't make any difference if you do a two-stage treatment and do something in the early years, and then do the fixed final alignment in the teenagers. But if you're looking at airway and width of maxilla and head posture, then that's something that's never been investigated. But there's so much anecdotal evidence, and once you work that way and you see these patients over 30 years and you follow them up, and I'm still bumping into families. I did them the other day in the sauna at the local health club, and I say, well, how's your son? And he says, oh, it's lovely, and he's got a nice smile. And I get a lot of that feedback, because if you live and work in an area, and you've been there a long time, you get to know all these families. There's no hiding, there's no moving on, and they pay good money for that treatment, and they're going to come back and tell you if they're not happy. And the thing about it, when I was doing the conventional treatment in the hospital, you take the fixed off and you give them a mirror, and they'd say, "Oh yes, my teeth are straight. That's nice." But when you do the other treatment, they say, "Oh, I like my smile." It's quite different, the width of the smile. When you widen the maxilla from a case which has been retracted, they haven't got, their lips aren't very full, and of course as they get older, the lips get even less full.
Yeah.
So the maxilla is the key. You really need to maximize on that growth at the earliest possible time.
Okay. So you said in the UK, if an orthodontist doesn't believe in a treatment or an alternative, he doesn't have to tell his patient. Here's my question. What if this orthodontist doesn't believe in physics? Are they permitted to are they permitted to, or can they get away with telling a patient information that completely violates the laws of physics?
Exactly. It isn't logical. It isn't logical, but I understand that we're right-brained and they're left-brained, and the left brain has got the speech center in it, and that's why they shout louder than we do. But we're getting quite brave now. We're getting our networking and the work that you're doing. I think we've reached the point of no return now.
Okay. So the take-home message for parents, and if we could word it so a child understands, what is the take-home message for that child?
But if the child knows that they've got crooked teeth, they're only too happy to have something done earlier. If the parent knows that their child has got breathing problems, then they also would want to start earlier. So it is to seek out a dentist who has, it doesn't need to be an orthodontist, a dentist who has taken the training to use these earlier appliances.
Or what about an orthodontist who understands the airway and who says to the kid or the adult, I will not restrict your growth. I will preserve healthy teeth and make sure your airway is properly grown.
Well, that's the best of all worlds.
Okay. So then, how about a good take-home message to what's the take-home message to a kid about their airway? And what do we tell a kid to make sure that they know what to run away from?
They want to grow big and strong, and they need the best airway possible.
Okay, so anybody who tells them that their maxilla is too far forward or their maxilla needs to be stopped from growth,
no,
it's dangerous. Okay. And make sure that if they're gonna do orthodontic work, that it enhances their growth and it promotes their growth.
Yes.
Okay. So they can breathe through their nose and grow to be strong. Okay. Any other last comments you'd like to share with any parents or people who are watching?
If you understand this and if this is what you want for your child, well then make sure that other people around you get the same message.
Okay. Thank you, Dr. Helen Jones. I'm going to stop the recording now.